today. The first is to talk to you about ECMO and give you sort of a basic understanding of what the ECMO is all about. A lot of it you've probably experienced in your time in Part 2 or CSI or wherever you've been. And then the second part is to talk about what we're doing with ECMO here in the setting of cardiac arrest, and that'll be roughly half of the time each. And we've got a lot to talk about. So I know this is basic, but I'll just start at the basics. So a couple of you have asked what materials are good to read on ECMO if you really want to learn ECMO. This book is sort of the Bible of ECMO, put out by the sort of premier ECMO organization centered out of the University of Michigan. And it's not cheap, but it also is very thick and includes basically everything. So it's not a quick read. It's not the CliffsNotes version, but it is a very good book for ECMO. ECMO is extracorporeal membrane oxygenation. It's also called ECLS, or extracorporeal life support. Basically, any combination of a pump and an oxygenator. You remove blood, you oxygenate it. You remove CO2, you put it back in. That's ECMO. Here you'll see Cardiohelp is the primary form of ECMO that we have, or the primary device. But really, any device that does that, including electronics, can still be called ECMO. Okay. The biggest point is ECMO is short-term. ECMO is not a lifelong solution. ECMO is a bridge to something. So we'll get to that. So just a little history. 1930, the cardiopulmonary bypass machine began with John and Mary Gibbons, with the first fully functional Part 1 machine. The first time it was used was in 1953 for repair of an AFD. Then came Dr. Lillehei here at the University of Minnesota, so it's a little ironic that we're talking about this here. Or maybe it's opportunistic. So performed the first cardiac surgery with cross circulation using a bubble oxygenator, which then went on for the next 20 years or so to be the primary way that people provided oxygen during extracorporeal support. So then came the person who's been attributed as being the father of ECMO, and that's Dr. Bartlett at the University of Michigan. He first in 1972 provided ECMO to a 2-year-old boy who had heart failure after a mustard procedure. He's credited with really bringing ECMO to children, which it had really resided in for the last 2 decades. Much more a childhood tool than, or a pediatric tool than an adult tool. So now, as we'll talk about the adult side of the thing. But like I said, he is at the University of Michigan, and as you read things about ECMO, you'll see a lot of things coming out of the University of Michigan, so the hub for ECMO. And then in 1989, he, along with others, founded the ELSO group, Extracorporeal Life Support Organization, and they really formed a registry. So now they collect data, they report that data to get an understanding and try to improve the way that ECMO is provided to children and adults. So there are many types of ECMO. Like I said, really it's just a pump oxygenator, remove CO2 with that same oxygenator, and then put the blood back in. So you can have that happen with venous-to-venous ECMO, with venous-to-arterial ECMO, with central or peripheral ECMO. You can have VAD confirmations where you really specify that RVAD support, or RV support, or LV support with an oxygenator, because without an oxygenator, it's not considered ECMO. And then your pump, you have many options for pumps. These are the two that we use primarily around here, Cardiohelp and electronics. Here's a depiction of those 2 types of ECMO. So the veno-venous, pull blood out of the vein, oxygenate it, put it back into a vein. Veno-arterial, pulling it out of a vein, oxygenate it, put it into the artery. These, of course, support different things. So VV supports the pulmonary system. You have very nice tight control of oxygenation and ventilation to all the tissues because you're replacing it in the vein. All of the blood is flowing close in there, gets all of the oxygen and the ventilation you provide. Coronary is online. There's no arterial puncture. The patients can be mobile. You may occasionally in 4E see them walking around here. We've had a couple that have gotten up and walked with their VVF. It's nice that you can do it in an IJ. It's a big catheter. But the big drawback that you just need to remember in VVF is there's no hemodynamic support. It's purely for gases. PA ECMO gives you cardiopulmonary support, so there you have hemodynamic support as well. You can, with the right cannulae, provide near complete blood flow support to a person, even with very poor or no cardiac output. It still provides oxygen and ventilation, but it's not quite as controllable because you have some mixing that we'll talk about later with blood coming through the heart if there is native heart function. It does provide considerable afterload that blood and that pressure into the arterial side. That's not something you have with a VV ECMO where, again, everything is coming through it. And then, but you do also offload the venous side. So you reduce the preload a bit, that's one blood out of the LA. So there is a benefit there. And then there is a need for arterial puncture. And it's really hard to get patients. There have been reports of people up and moving around with VA ECMO, but it's much, much harder than VV. So the cannulation options, I mentioned some of these already. Peripheral or central. In VV or VA, different options. So on the venous side, you can go in the IJ, directly into RA if it's surgically placed, the femoral vein or the pulmonary artery. Again, the pulmonary artery would be surgically placed. On the arterial side, people go into the carotid. They go into the aorta, femoral artery, axillary subclavian arteries. Occasionally, you'll want to offload the LV. Again, there's a lot of afterload provided by the arterial flow from VA ECMO, and that may prevent blood flow from, or blood from leaving the LV. If the LV is particularly weak, the LVDC can increase, can cause stagnant blood flow and clot formation. It can also cause more injury to the heart. So on occasion, you may want to place a line to vent the LV. You can do that by either venting the LV directly or venting the LA. Oh, don't worry about it, just be reminded of that. Thank you. So if you can look on echo and see, so there are a couple ways. One is hemodynamic measure. So you look at your wedge in the swan, if it's gargantuanly high, that may make you want to do it. If you have no function on echo of the LV, if your aortic valve isn't open, those are the other reasons you'd want to vent it, again, to prevent clot. So it's really only used, generally at least, for those people who have very severe LV dysfunction and no blood flow. Then there's, in VA ECMO, again, you can go femoral to femoral, which is what we're doing with the peripheral ECMO, which I'll talk about. But then in an open chest format, you can go RA to aorta. You can effectively make it like a VAD and just go LV to aorta. Depends on DV, you can go femoral to right IJ. You can just have a dual lumen catheter, the Avalon catheter, which is entirely right IJ. And you can, again, go surgically and have RA with PA. So here's the most commonly used, and the only one here that's used here, VV cannula, called the Avalon cannula, made by MSK. It's a dual lumen cannula. So basically, you remove blood and you put it back through the same cannula. It has two ports that remove the blood. One ends up essentially in the SVC and one that ends up in the IVC. And it has the lumen that comes out and needs to be directed toward the tricuspid valve. You direct that under echo guidance and place it. This cannula can range in size for adults between 20 and 31 French. And it's again going in the IJ. So it's a big cannula. That's a very small one. Their example is very friendly looking.
Why is it so important that it has to be pointed at the tricuspid valve as opposed to just getting it into the RA and let it get a normal heart?
Well, so it's it's not a circumferential opening. It's only on one side. So if you direct it, if it's not directed to the tricuspid, it's basically directed to the vascular wall. Well, you mix it too. And right, so you get recirculation. But so when it comes to VA cannula, size is everything. And it's true it's the VV too, but it's VA cannula. Yeah. Trying to keep you on task here. So of course we know the resistance is determined by the length of the tube as well as the force power of the radius. So that's where the size is a very big issue here. The arterial cannula is typically between 15 and 21 French. 15 is the lowest you go usually in small people because it doesn't give you as much flow. 17 to 19 is the most common. The venous cannula also restricts your flow quite considerably, and it's actually the longer of the two, and I'll show you that. And actually, you can see that here. The blue ones are the venous ones. So they're considerably longer. And because the venous side, and we'll talk about the flow restrictions there, is such an issue, you need much larger cannula. So usually those are 25 to 29 French that we're using, but technically it goes down to 15 French as well. And then in people, when you're using a larger arterial cannula, you also need, because you're likely occluding that artery, to have antegrade flow. And so you place an antegrade flow cannula down the femoral artery. And for this, you need to use a particular sheath that has a large side bore tube, so that for the same reason that you need a large radius for your arterial cannula, you need blood flow to that antegrade flow cannula. So you need a very large bore, which is provided by this 9 French sheath in this kit. You can't just use a 6 French or even the 9 French that's sitting in the capsule. You need to use a particular sheath. So yeah, I said the primary unit that we use here is Cardiohelp. So Cardiohelp is nice in that it's all one machine, and it's actually very compact. It's a centrifugal pump, and it has a Quadrox Oxygenator. It's just the name for the oxygenator. It's the one that is shaped like a square, and it's this red one shown here. It's incredibly portable. Because it's a centrifugal pump, much like VADS, and you're going to see a lot of analogies to VADS here, it's very preload and afload dependent. It can support, theoretically, at least through the filter, 7 liters of flow. Not something you're going to see in people, but it can. And the machine itself monitors a whole slew of different factors for you. So it monitors the flow, the RPMs that you set. It monitors the pressures in and out of the circuit, as well as the pressure within the circuit. It monitors the hemoglobin, which you have to calibrate first, so it does monitor that, the SpO2, and then the temperature for blood leaving and entering the circuit. The oxygenator looks like this. So you have blood flow following the red arrow. You have gas flow, which is traveling along this green arrow here. The gas flow is providing oxygen, but the flow is actually providing ventilation. So it's removing CO2. So this is how you adjust the pH on the blood gas once you have some doing that. And then there is water flowing through as well, so you can control temperature. So not all of our units are set up to control temperature, but many of them will. They don't have the finest control, but you can at least regulate temperature a bit.
The standard sweep in that means for 2 liters.
It's really not. I mean, it can vary a lot, but that's sort of an average. Just to give you a sense of what is on the surfaces that we're using. So again, we have the Cardiohelp, which is from the clay. They use this surface called Bioline. Basically a combination of heparin and albumin. Other companies have other surfaces. Many of them are heparin, at least related, but you're not going to see these at our institution. So some generalized risks and benefits of ECMO. So biggest risk, well, it's hard to say what the biggest one is. Bleeding is a big risk. You have a large cannula in an artery, in VA activity. And you have them on anticoagulation, which we'll talk about the specifics of, but they have to be anticoagulated to keep fibrin conforming on the surface. You also have a very real threat of clot and air emboli, because again, you're pushing blood into the arterial circulation. So anything you put in has every right to go straight to the brain. So you're very careful at the beginning to get all the air out, and another reason to make sure clots aren't forming on the surface. So most of them will form and be caught on the venous side. So you have to make sure you're well anticoagulated to prevent this from going more. Infection is a risk. Transfusions, because they often will require transfusions to maintain their blood counts to hemolysis and platelet consumption. So transfusion reactions are a risk. And mechanical failures, though these are very, very unlikely. I've yet to see one which we failed. But the perfusionists are also very fast. They can stop open circuits in a matter of seconds. And we train for disaster scenarios. The benefits, though, so this is, risk bummer, but the benefits are also many. So you have the ability to fully support somebody, their cardiac and respiratory function. You can basically decrease the vent settings to the point where you're just resting the lungs and allowing them to heal, or at least preventing barotrauma. And when you think about cardiac arrest and CPR, certainly those lungs have taken a bit of a beating as well as the ischemia and perfusion. But the barotrauma, that once we put them on the vent, can be even worse. And then you have the opportunity to basically eliminate, for the most part, inotropic support. So the side effects, the arrhythmias, the increased metabolic demand that come with inotropes you can almost entirely eliminate in most situations with the support you can provide through it.
Do you, when you give a blood transfusion, you go through the ECMO circuit, or?
So they can put a lot of things directly into the ECMO circuit, fluids and transfusions, but it doesn't necessarily provide you any benefit other than having those forms of action.
Maybe a little faster.
Yeah, I'm not just really pushing it faster than you can put it through.
So that should be where the two right now.
That's a good question. So the indications are many. Sepsis, back in the day, used to be a contraindication, but as flows have increased, it seems like it's now been added to the indication list. Because now we can support somebody with low SVR. Pneumonia in particular is a classic indication for VV ECMO. Anything that's reversible on the cardiac side is a great indication. So a cardiomyopathy, a myocarditis, a PE that you could remedy, and then aspiration pneumonia is another great one for VV ECMO. People do very well coming off of the VV ECMO as their aspiration pneumonia resolves. And then ARDS is another indication. It's considered at the time of putting ECMO on that this person has at least 50% mortality. So when you're talking about a family, or to a family about ECMO, they have a 50-50 chance of survival at best in that situation. Otherwise, they probably shouldn't be going on ECMO. Contraindications, basically conditions incompatible with life. Pre-existing conditions which would affect their quality of life for people with things with mental status. All these are relative contraindications. There are actually no absolute contraindications. Not a single one. But certainly some of these are more relatively strong than others. So people with baseline mental status issues or with end-stage malignancies certainly would be less likely to get ECMO. I have an idea who this is. People with risk of systemic bleeding, brain bleeding from either trauma or recent major surgery or recent head bleed. Age, if somebody is, as they get older, less likely to benefit, and as they get larger, it's harder to support them. And then the futility, again, ECMO is short-term, it's a bridge to something. If there is no land on the end of that bridge, don't get them on the bridge in the first place. Okay, so for adult respiratory failure, the specific indications for somebody for VV ECMO in this situation, again, 50% mortality, and they have some cutoffs for PaO2 less than 150 on more than 90% of oxygen, or an 80% mortality where they figure with PaO2 less than 80 on FiO2 greater than 90%. These are just two cutoffs that you'll see the people using, and you'll see in the literature. So, CO2 retention, again, if you're out of options and you get CO2 off, short of tracheal insufflation, which is something that's used around here but not very effective, then it's another indication for VV ECMO. Again, you can ventilate pretty well in this circuit. Contraindications, somebody who's been on high vent settings for more than 7 days, and when I say high vent settings, I mean keep in the 15 to 20 range. The idea being here, at this point, you've already hurt the lungs enough. Recovery is not going to be all that helpful. Recovery time provided VV ECMO, and so the thought is that you have the point of diminishing returns after about 7 days of really pummeling the lungs. Somebody who's got major immunosuppression because the risk of infection is high. Somebody with CNS hemorrhage or increased mortality with increasing age. Again, all of these are relative contraindications. Cardiac failure indications would include basically everything that we see. Everything including cardiogenic shock. The contraindications, if they have an unrecoverable heart and they have no other outs, again, the bridge to something. They have chronic organ dysfunction. You know, it gets into an issue with the same thing that we see with VAD. If they have renal dysfunction and they're going to be on dialysis with their VAD, we tend not to put the VAD in. If they're not going to be a VAD candidate because of that, then that's an issue. If they have other organs that are dysfunctional to the point where they're not going to survive for long, that's another issue, relative contraindication. Prolonged CPR always shows up on this list that I'll talk to you about. And prolonged CPR is now going on here. That is going to be, we're considering this very relative.
Contraindication, I didn't know that.
Yep. And anticoagulation issues, obviously, they have to be anticoagulated. If they don't have to be on heparin, though. They can have HIT and still be on ECMO. People are using bivalirudin, dextroband, so they're alternatives to heparin. If you can't accept them. So you just one note, you can do dialysis on ECMO. The nephrologists are actually pretty happy they can hook into the ECMO circuit, and it's really rarely ever have a problem. It's actually better than the lines that they're putting. So don't worry about that. Then there's what I'm calling ECMO Plus. So ECMO Plus an Impella or ECMO Plus a balloon pump You'll see this done in some of our folks, but also in some of the literature. So the thought is with the Impella, you vent the LV. It's a way of getting that blood out without doing a surgical vent. It could be beneficial in severely reduced EF. The jury's still out there on whether that's really beneficial over population. But it is thought, you make sense that you reduce the thrombosis. Then the balloon pump, it does seem, at least in some circumstances, it does seem to reduce the afterload in the ventricle, the LV. So whatever function is there has a little usually chance or time to be removed by the LV, and also it increases your blood pressure and increases your pulmonary perfusion. So you see a benefit to both of these, and you'll see that they're done occasionally or intermittently.
Question. So when you go from ECMO to like a permanent BAD or BiBAD, do you have to go on to cardiopulmonary bypass, or can the surgeons go directly from ECMO to BiBAD?
So they can go to temporary BiBAD, is that like the electronic or RVAD, LVAD system?
Yeah, do they have to use
They can go straight on.
cardiopulmonary bypass? Because ECMO is like
It is.
cardiopulmonary bypass.
And they use peripheral ECMO in ORs.
Okay.
So no, they don't need to have a step in between.
Okay.
We haven't switched any of our people over, because the surgeons will occasionally do that, especially for their post-op people that end up on ECMO, they can't get off bypass, and they have them on ECMO. They give them a little time, they don't come off, and they'll switch into a temporary RVAD or LVAD, essentially.
So, ECMO plus Impella balloon pump. I mean, especially with the Impella price that goes 100,000 plus cost to the patient. Are there any studies or have anybody looked at before about going down on the flow, retrieve the afterload on the heart, especially now with the flow, sounds like it's been run arbitrary. I mean, 4, 3 liters, 3.5 liters, just from the map of 85 and 80, but does going down on the flow is equivalent to adding Impella?
I don't know that anybody's tested that rigorously. We have seen that when we have our people and we go to, so turn down studies are very frequent for everybody who's on ECMO, so that's not just us. But when you turn down the flow, you certainly can see more pulsatility, one, because you're not reducing the preload so much, so the heart actually has some preload, and also because you decrease the output. The problem is when you get in somebody who has such bad LV function, or RV function for that matter, that they can't actually either fill the LV or contract enough to pump enough blood out, so you mask them part of it. So the Impella can give you that support when you just can't turn it down and maintain perfusion pressure. It'd be a nice study to do if you had the right population. You could actually. So troubleshooting ECMO. So what happens when you're here in the middle of the night and you get that call that there's some alarm, or you're walking past the alarm?
Can I just volunteer? This is an important lecture part for all of us because we're going to be cross-covering ECMO patients already. So, Jason will ultimately, unfortunately, still have to be called. But I think the idea is for you to think about it and pay attention to how to troubleshoot, think about some of these issues so you're ready to adapt to them versus becoming an intern and just making a phone call.
Which I love to talk about.
Yeah.
And I'll be talking toward the end about how that's all going to work. But yes, troubleshooting ECMO is a good thing to know anyway, because you've already been cross-covering people. While the surgeons are technically stopping in to say hi, you've still been getting calls by ECMO people at night on part 2. So these are things you want to know. There's nothing else to that, but you'll want to know even more soon. So the first thing is low flow issues. So low flow can come about from a lot of issues. One, the RPMs just aren't turned up. That's usually not the issue. The perfusionists are very good. So if they're concerned about flow and mass, they've already tried cranking up the RPM. They've run into one of these other issues. And oftentimes, the most common one is low preload. And what they say is the lines are chugging. And so if you've ever seen it, the line's actually jumping. It's moving because either the catheter is getting sucked up against the wall or the wall is getting sucked up down to it. But it's basically the flow is stopping for a moment, and then it releases, and then the line jumps.
What degree is considered chugging? Are you tolerating a little vibration? Then it comes none whatsoever.
I mean, if it's enough where you can see it without like getting your face on the tube, then it's too much. So the biggest reason, again, is low preload, and that's coming from either new bleeding that you didn't know about, and I think many in this room have run across an ECMO patient who just starts to have a retroperitoneal bleed or something out of the blue and becomes a serious issue, and that's the first sign you have of that, is chugging. Vasoplegia that came about from post-cardiac arrest syndrome or sepsis or something, so they become vasoplegic, their CPT actually drops, they keep more of the volume in their abdomen or periphery, and their CPT drops and they start to chug. Or the venous catheter will change position. Should never happen with ours because it's sutured in 18 different ways. But that said, if it gets pushed up against the wall, it can actually start to chug just from position. So that's another thing to check. The other issue with low flow can be afterload, just like VADs. If you have a hypertensive person, their flow will slow. And so if you've added a lot of pressors, vasoconstricting agents, then you can actually reduce flow just with that. Or if they recover spontaneously and have hypertension. So just keep in mind, you'll notice that a lot of these are actually very similar to VADs. So if you apply what you know for VADs, ECMO, you'll do pretty well. The centrifugal pump is much easier.
So going down on the ECMO is not going to cause chugging?
Going down in the RPM?
Yeah.
No, that's how so when the tech sees or the perfusionist sees chugging, they actually will drop their flow, or their RPM to decrease the flow to accommodate and stop the chugging momentarily while you try to get your preload up. So it doesn't cause dropping the RPM
to go together, like, so it follows. Okay.
Right.
The venous catheter position, UAE, for the position.
Chest X-ray. And I'll show you the venous catheter, but it should be right in across the right atrium, with the top of the cannula, pretty much an SVC, just right at the cusp of SVC, and then going down, and you'll see it. I mean, it's long enough to cover all that space down to the growing where it comes up. So that's, of all the reasons for this, that's the least common. Usually it stays put very well, but the other two, bleeding or vasoplegia, or just, they've urinated a lot because you're diuresing them and then they get dry. A lot of factors. Clotting in the filter is another issue that comes about. Usually it's because of just long-term use. These things, just because I know you're curious, these things are FDA approved for 6 hours of use. So how many ECMO people do you know that have gone on for 6 hours and been taken off? So we are not using it as the FDA has approved it. It certainly lasts much longer, but over time, fibrin collects, and you'll get clotting on the filter. The pressures across the filter will be higher. You can get more hemolysis. But in any case, that can make the clotting worse. You can develop HIP from the heparin that you're giving them for the ECMO. And then your ACT may have drifted. Perfusionists, again, are very good about keeping their eyes on the ACT. That's not usually the issue, but again, just keep all these in mind. Air alarm. So if you're going to have an air alarm, usually it's at the beginning. Basically, the machine is very sensitive to any bubble, because again, if you send that bubble up the arterial side, it's going to go possibly to the brain, depending on how lucky you feel like it. So it's very sensitive, and it will just shut the ECMO off. The alarm detects a bubble, and it turns it off. Flow stops. So if you were dependent on ECMO, you no longer have the ECMO you were dependent on. Most of those things happen initially when you're attaching cannulas, because there's a little bit of air in there somewhere, and that it will get picked up there. But the interesting thing is Oxygen sets it off. So your very nice echo tech shows up, doing the echo, you're like, well, of course you're going to use contrast, I want to see what the function is. They give the contrast, and the machine shuts off. Just be ready for that one. Because you watch the maps, just drop. So it's, just keep that in mind. Pulse with lower extremities. You'll get this call from the nurse frequently. Oh, I have no pulse, I can't Doppler or pulse, on and on. Well, do they have any pulsatility anywhere else? If they don't have pulsatility anywhere else, they're not going to have a pulse in the foot. So, number one reason for a pulse with lower extremity is that you just actually have non-pulsatile ECMO flow. And that's it. So you need to know that. If they have pulsatility on their radial arc line, but they don't have any in their foot, that's a different story. Check their capillary refill, check the temperature of the foot. We often will put NIRS, the near infrared spectroscopy, with basically O2 sensors on both legs, and trend those, so we'll know, especially if we think we have a vulnerable limb. Most likely, if it's not because of the flow And it is actually because of occlusion, it's in the foot that you're occluding with the cannula, because you've got a large cannula and an artery. You can get an arterial deflex. Usually they say they're slow, but it's just going to pulsatile as expected with ECMO. Yes?
What happens if the chief?
So, perfusion, so you look at the perfusion, so this helpless look, and you're like, please start it up again, and they do. That's it. So, yeah, so it's not like it stops it permanently, but it shuts it down and the alarm starts going off. So what they will do is they will turn the RPMs all the way down to 0, they will turn it back on, and they will ramp it up slowly. So you've got maybe 10 to 20 seconds of no flow. There is a hand crank. Don't use that. Yes, there is a hand crank. There it is. So then the last thing is a low PaO2 on an ABG. So as we'll talk about, you always want a right radial art line with all these people. And this because of this phenomenon, which some people call north-south, some people call mixing cloud. There's no fixed name, but around here it's north-south syndrome. And that's this. Basically, blood is flowing. If your heart has some function, it will still be pumping blood to travel to the lungs. However much oxygen it picks up in the lungs is the oxygen it will carry with it. So if it pumps a lot of oxygen through the lungs, and you've decided you're not going to give the lungs any oxygen, that blood traveling through the lungs will have no oxygen and it will be pumped out into the system. Meanwhile, your ECMO is pumping very well oxygenated blood from below into the femoral artery. And it's going as far north as it can until it meets that blood flow from the heart. So it's possible, if your heart has good function, that it will actually meet somewhere in the middle, and that you'll actually be entirely blue from the chest up. I mean, at some point, you will be blue, potentially. So if you have a radial art line in the right radial artery, that's the closest branch that you're going to be able to detect, short of putting a catheter in the coronary, to what that oxygen saturation coming out of the heart is. In somebody who has got severe dysfunction, that's going to be the same oxygen saturation as it is down in the groin, because it's just in the ECMO flow all the way up to the brachiocephalus. But in somebody who has some heart function, it will be what's coming through the lungs. So then you can gauge how much ventilator support you have to give them. So the north-south syndrome is when, again, you have differential oxygenation, and unfortunately the brain, which is on the top portion, is getting the poorly oxygenated blood from the heart.
This should matter where you cannulate too, right?
It matters if you cannulate not in the femoral, but your cannula position, if you're going from the femoral, will not change. Your arterial cannula is about 15 centimeters long, and it will just be planted usually in the iliac, actually. It may reach into the aorta, but it's usually just sitting in the aorta.
So advancing catheters.
You can't advance it far enough. So the only thing to do is just keep an eye. If you've got good pulsatility, you can actually get an O2 stat monitor on the right hand. That's easy. Otherwise, you just have that art line in the right radial artery, and you just have them check ABG. And they know, I mean, oftentimes they'll prompt you if you haven't done this already. They'll say, hey, what do you do with the right radial artery? But the arterial, the PaO2 of blood coming through the ECMO can be 500. And then your PaO2 up here is sitting at 50. And you don't check, you don't know that. Okay, so what's happening here? So what's been happening here is basically ECMO for refractory VT. It's a protocol change, a protocol expansion, really. It's not, we're not doing an official research study. We're applying a protocol with a relative, quite intense quality improvement effort. So there's still a lot of data being collected because we're continuously changing the protocol. But the expansion is coming from this initial finding that was actually from 1997, which is if you take all people who have VF arrest, and you look at their presenting rhythm on EKG after they have ROP, 42% or so will have a stent. The rest of them won't. Yet, 71% of them have coronary disease significant enough to fix. 47% will have an acute occlusion, which is more than the 42% of the stent. So if you take 42% of people who didn't have any reported chest pain or ST elevation, 26% of those have an acute occlusion. So if you have underlying coronary disease, you can reverse that. That's the underlying idea. The initial protocol that's been going on now for the last 4 years or so is this, which is that everybody after cardiac arrest, or after VF cardiac arrest, goes to cath lab. Many of you have grown up in that. It's just, you haven't known anything different. That's always what we've done. It's been only the last few years, and still it's not done across the nation. I don't know if it is done in the way from. But There have been some criteria used to select out those people who are most likely to do well, but really it's pretty broad. And it's actually similar criteria to what I'll talk about for the ECMO. People less than 75 years old or over 18, people who are not DNR, people with no obvious trauma, people with no known terminal disease and no ongoing hemorrhage will go into the yes group, which will then, will go into the no group and get PCI. If they have any of those things, then they go to yes and they just get the standard protocol, which at this point is still the rest going to the cath lab. It's becoming standard across the city because of this effort. So the benefits or the outcomes from that were actually quite nice. So of the group that fit the protocol, 85% went to the cath lab. Most of those who didn't went because cardiologists said no. The people with early access, 46% of them had PCI, 5% had a cabbage, and 38% had an STD prevention. 75% were discharged alive. So 75% after VFRS, which is a pretty solid number. 95% of those who were discharged and had cath lab access had a good CPC, which is cerebral performance category, which is basically neurologic function. So they basically had good or only mild deficits in their neurologic function. People that didn't go to the cath lab, only 42% were discharged alive, and 79% of those still had a good score. So basically, granted there's some selection going on here, but it seemed like a lot of people were going to the cath lab, a lot of people were having disease that was fixed, and they were doing much better than you'd expect from national averages.
What about sometimes people go into PEA or RS and then DF or RS? Are you
presenting rhythms? So if they're presenting rhythm as DF and you shock them into PEA, they're still DF.
So this includes them, okay.
So they basically concluded that cardiac cath lab access as part of this post-resuscitation care package is feasible and may improve survival. Of course, this is all for registry data, but still may improve survival. The protocol deviations were common, despite the standardized protocol in most of the cardiologists. And then expected survival for this population is actually much higher than thought, and neurologically detected survival is much higher than thought. Now, it's possible that the cardiologists that were saying no for very good reasons, and that's why this group did so well, and the people who were selected out were absolutely selected not to go to the cath lab. But that is yet to be determined. The other thing that came out of this, though, is that if you look at the people who went to the cath lab, they were much more likely to get additional support, like a balloon pump. So 16% of people that were in the protocol got a balloon pump, 2% of the people who didn't go into the protocol or didn't go to the cath lab got a balloon pump. So this suggests that there might be a need for mechanical support. If you look at the literature, there is one trial, the SAVE-J trial, that includes 454 patients in Japan. It's, again, it's a bit of a registry trial in that they had certain medical centers that were selected. They were randomized by what they did before. They weren't randomized truly. So if you were an ECMO center and you wanted to be an ECMO center, then you ended up in the 26 that were doing ECMO. If you weren't, you didn't, you'd be in the 20 that were not doing ECMO. Makes you wonder a little bit about the additional care they were providing if they were not providing ECMO. But that said, they tried to look at this question: does ECMO, in addition to resuscitation, help? The majority of them in both groups still got a balloon pump, so really there's the addition of ECMO. And when they looked at their numbers, 12 versus 1.6% had neurologically intact survival at 1 month, and 26% versus 6 survived to 1 month. So as opposed to neurologically intact. So this includes some people who are not so neurologically intact.
So one question about the study that is limited one out there show that there is almost, 25% increase in the mortality benefit to neurologically intact patients. But the question is, what is the percentage of the patients that are not neurologically intact?
So here, there's about, there'd be about 50% of the population that survives is neurologically intact. So, and then at 6 months they get a little drop off, but not too bad.
Because you get all those patients that were on ECMO and now they are not neurologically intact. Do they stay untouchable? Do they?
It's a conundrum. Yes, absolutely. Then they don't stay on ECMO. The decannulation, right? I mean, they can't stay, first of all, because they're going to have some competition, but also the decannulation still happens. But then you're right. There's an ethical and sort of a societal dilemma. You have all these people that are not neurologically want to take care of their relatives to the bitter end. And in other groups, they would say, you know, this is how my relative wants to live, let's be done. And to some extent, that'll be a bit of a case-by-case basis. Then there's the ALTO registry I mentioned. It's international, 298 centers, 2,400 patients. Their rates of decannulation are 40% of all comers who got ECTR. And these are more selected people. This is a registry where they truly are just selected people who go to the registry. And then 30% survive discharge. So they have considerably better numbers, but at the same time, again, some selection bias. So what are we doing? So refractory VF, that we're calling refractory VF, includes patients who have gone through, received 3 shocks at least, received epi, and received amnio or lidocaine. At that point, they become labeled as refractory VF. They can have intermittent rot with recurrent VF. Or after they get their amnio, they can end up getting rot, but they're still in this group because they were already declared refractory VF. So if you look at that group already, what we know of it, 48% of them, of all patients with VT and VF, not refractory, but VT and VF in general, survive the discharge. 72% of the patients that are evaluated in ED survive the discharge, with overall VT and VF less. But if you look at refractory VT and VF group, less than 8% of them survive, currently in the study. So as soon as you get amnio or lidocaine, you have a less than 8% survival. So what we've been trying to do is take that group of people who are obviously very high risk for death and give them a better shot, knowing that it's not going to be 100%. So again, the population we're looking at is people aged 18 to 75 with refractory VT. They are treated by paramedics in the field for those first few minutes, getting them to the point of giving amnio. At the point that they do, they call their emergency medical services director, who then determines whether or not this person would qualify, which they do. There aren't too many criteria, as we've seen. And then they call factory nurse. So he activates the cath lab here, and they all come to us. At which point, they get arterial venous access under ultrasound guidance. We get a blood gas. That'll feed into some of our criteria down here. While that blood gas is cooking, we get a pigtail. We put a pigtail up. We look at their vasculature. If their vasculature looks like it would accept somewhere between a 15 and 19 French, so usually again 17 to 19 French, arterial cap from the cannula, which is the limiting factor usually. If that fits, then they're good for ECMO, as long as they went from their EMS call or the 911 call to the cath lab within an hour. Turns out most of our people are arriving at the hour mark, plus or minus 10. If they've been here within an hour, or gotten here within an hour, and they look like they'll accommodate arterial cannula, then we look at these inclusion criteria, which are to some extent based on that ABG. So was their end tidal CO2 over 10 when the paramedics were delivering CPR? They'll tell us that when they arrive. Was their PaO2 on that ABG greater than 50 or O2 sat greater than 85? They don't always have O2 sats coming in. We don't actually have nerves in this cath lab, but this is one of the things we're talking about including. And then a lactate less than 18, which comes off the ABG. It's a very loose criteria, right? So normal end tidal 40, right? So most of them are in the 20s to 30s. So really, this is failed resuscitation is what we're assessing. If you come in after an hour of resuscitation and you have a lactate over 18, your end tidal is less than 10, or your O2 stat is less than 85%, they just haven't really, for whatever reason, haven't been successfully resuscitated. And so then you don't fit the criteria. And you would possibly still get a balloon pump, still get a cath with mucus ongoing to see if there's anything reversible. But the likelihood of neurologically intact survival drops considerably if these are not met. And so we don't want to dedicate that person or that family really to 2 to 3 weeks on ECMO before we're willing to say that it's not. So if they get ECMO, place them on ECMO, do the angiography. They may get a balloon pump or an impella, like I mentioned. We reverse anything that we can reverse. If there's something reversible, then we give them extra time. And that's really extra time to get a perfusing rhythm, or at least a rhythm. It could be perfusing. Should we turn off the ECMO? We usually don't do that. But if it's VF still, that's not going to be successful under any means. So if we're giving shock after shock, even after fixing all this, and we're not able to get something sinus or PEA, then we're going to call it and clear it back. If there was nothing reversible, we still give them some time for medications and to shock them out. But if we can't get them out, then again, we declare death in the catheter. So a few cases. So first guy, 66-year-old gentleman, has a prior history of TBI, though he's living independently, had a witnessed cardiac arrest at a restaurant. Bystander CPR was initiated, and EMS showed up in 4 minutes. EF was observed on arrival, got 2 shocks, and got robbed. Then bringing him in as a routine TBF arrest, he goes back into VF, he gets epi, multiple doses, he gets amnio, and he's on lucid CPR and VF still on arrival. Intubated in ED and comes to the cath lab. All right, angiogram. There. So you've got OM disease, you've got LED disease. And the yellow ring is here, which is also. He ended up getting a experimental stent at OM, and he got a public of the ramus, couldn't cross the LED, and if you have other images, you can see collaterals filling in the distal LED from the OM. So the biggest thing is the OM. And here's that cannula shot I was talking about. So that's where the very tip of the cannula is. We can go over down. And then you'll see right at the end, the arterial cannula, CPM, right over here. Okay. So that's as high as the arterial cannula gets. But the venous cannula goes all the way up to the right. Did a whole series of labs for this guy. His pH isn't so bad. His creatinine initially not so bad, and actually never really was all that bad. His EF initially is 5%. Following day, doing a turn down, so that's on full flow. Doing a turn down, EF goes up as high as 35 to 40% on 1.5 liters of flow. The flow limit that you go down to is based on multiple things, including their maps and what they're tolerating, as well as their ACT at the time. You can't go really well with their ACT in all aspects.
Question about, one about decannulation. Can you decannulate just by moving the cannula, or does it have to be cut down with suture? And the second question is, since you're reversing the physiology of the circulation, does using the SWAN numbers are still valid in this patient?
Good question. So the first one is the decannulation. So we, for the most part, will surgically decannulate, though we've now done one bedside decannulation with a 15-French arterial cannula in a person who is a great candidate, very skinny, good compression, needle stick was great. So we will likely do more bedside decannulations in the future, but it will be selective. The tradition here has been all surgical. So in terms of the SWAN numbers, we haven't been using them so much to get a true cardiac output, because you're right, you really can't. You're, in many cases, hyperoxygenating the blood distally, and so you need correction factors for that, and the fudge factor and all that. Plus, our people get hypothermia, and so the assumptions we make for their metabolic demand is also way off. So we don't use it for a strict number. And actually, in the severe cases, or early on at least, we can usually use the flow from the ECMO as our cardiac output. And at least we can use it as a low estimate, because we know we're delivering at least 4 liters. That's the lowest cardiac output they could possibly have. But we can still use that mixed venous to see if that's significantly different from the mixed venous that gets back to the ECMO, because the thing that the ECMO mixed venous misses is coronary sinus return. And if that mixed venous at the tip of that swan is so much lower, that's telling us we're not really getting enough oxygen to the heart. The coronary sinus blood is so depleted that it's making a considerable change in that. So we can still use it for that, and then we use it once the ECMO comes up. We do use the PA diastolic, the pressures, to tell us how our turn down is going. So in terms of the hemodynamics of the turn down, we look to make sure that our LVET isn't climbing, because LV isn't completely failing while we're doing this turn down. So it's useful for that. And then we do use it for rough estimate of CVP. Even though we're pulling blood out of the right side, you can get a little sense of the preload at the ECMO circuit, at least, from the CVP that comes from SWAN as well. So there's a benefit to having it, but it's not the benefit we used to in sort of traditional heart failure. This guy on hospital day 4, or sorry, he was decannulated the next day. So he did really well. Again, EF 35 to 40%. He was extubated on hospital day 4. Ejection fraction was 54% before he left, and he left on day 8. So he actually went to a TCU that was right across from his home, because he felt like he wanted some extra support. But he could have gone home. and he truly was the first guy. It's always nice when that's successful. Not all of them are like that. This one is though. So they don't get them in trouble. 55-year-old woman, paxacrine deficiency, had a stroke in the past. She rear-ended the truck in front of her when she arrested. Driver in the car, pretty low speed, but still. Driver saw it right away, called EMS. He didn't do any bystander CPR for whatever reason. Got epi, amnio, and bicarb. Had intermittent rocks on the way in. End-tidal is 21. PaO2 is 324. This obviously is excellent. You don't get that on normal people without ECMO. Or without supplemental oxygen, not ECMO, but supplemental oxygen. And then she got a balloon pump. She never actually did get ECMO. Turned out her function was so good initially, and you could see pulsatility in her heart lungs initially, that she never did require ECMO. But what she did have is this LED dissection. Spontaneous dissection, no coronary disease anywhere. Wired the dissection with Lucas going, and stented it up the office. And had a great result. She got therapeutic hypothermia for 24 hours, removed the balloon pump on hospital day 3, activated the next day, and she went out to the CCU. She actually came back with 100%, which was then fixed, and she was sent back home. These are her echoes. So this is her initial echo. So pretty sad initially. This is before she left. So you have 25%, maybe been more, but still 25% initially, 50% on discharge, and she had an MR that she said 46% as well. When you get MR. And importantly, her LED territory was viable. Okay, so case 3. So 53-year-old woman, history of alcohol abuse, admitted with refractory VT, witnessed at home, again, no bystander CPR from her husband, arrived, EMS came at 11 minutes, then Lucas was initiated. She got 6 shots with intermittent PEA, amnio, epi, magnesium was all given, end-tidal was 39 when she arrived, and OT sat was 90%. ECMO was put in, 15 French artery, this is the one who had the 15 French artery was removed at bedside, spoiler alert, now. 25 French venous Cannulas. So she had nothing. So this is what a heart looks like on ECMO and VF. It's not moving at all. She has coronary perfusion because of ECMO. It's these great coronary anatomy. That's another. She had no disease, got 13 more shocks. 1 to 2 beats of PEA on occasion, then we go right back into VF. Lidocaine, metoprolol, Versed, propofol, we gave her everything we could. Sort of a stellate ganglia block. She got everything. And continued perfusion with ECMO, so she had no issues with ischemia during that time. So we were about to call it, and we said, what else can we do? And we gave her a shot of potassium. So she got 1 milliequivalent per kilogram potassium bullet. This is what happened. She went from VF to a distalish, became sinusoidal in 2 to 3 minutes as the potassium redistributed. We shocked her, and she went into sinus. Stayed in sinus from there on out. The only reason we can do this is because she's on ECMO, and we've got the hemodynamic support to provide flow to her brain and everything else, while we basically give her a lethal dose of potassium. The peak potassium level was 8 after this. I think it was normal in a half hour, just redistributed. So no long-lasting issues. She's still recovering. She's in the hospital for some reason. She's moving around, not really following plans all that well, but she's having some recovery. This is her most recent EKG. Her echo is actually quite interesting. We don't exactly know for sure what it is. This is the initial one. But the thing that's known right away is thick. She got very thick walls. She got more function back, but still very thick. Trabeculation is very prominent. There's concern for LV. So, don't know if she had no coronary disease. Did she have an underlying cardiomyopathy that she didn't even know about that kicked off the VF? Why it was so resistant, it's hard to say, but it broke eventually. So again, only because we could do things that, and as a last-ditch effort, I mean, everything else was tried first, but try to give her every shot. So she, as like everybody else, therapeutic hypothermia for 24 hours. Cannula is ECMO, hospital day 3 at the bedside because she's a small woman and she has 15 French. have some non-convulsive seizures once rewarmed, which is not necessarily a bad sign, though it can delay recovery. She's on Keppra. She has an MRI that shows diffuse anoxic injury, though a case I won't show you actually showed this thing that the neurologists talk a lot about actually improving for one of our guys. So has diffuse anoxic injury, and the next MRI suddenly it's gone. And so we haven't gotten a repeat for those, so I hope it's going to improve. She's had some neurologic recovery, but of course she's not ready to discharge. She got traced and there, as did this other guy who woke up after 2.5 weeks. She's gotten ventilator-associated pneumonia, which is a theme for these people. As you see, even from these two cases, the heart is rarely the big issue at the end. They rarely have heart failure or horrible heart function. It's usually everything else. So brain function, lung function, renal function. One of our other people required dialysis. She did not. Most of our people have not, but we have one who did. So, you know, it's very much critical care. This is cardiac critical care at its finest. And heart failure is not actually such a big issue overall. The last one didn't go so well, and I just want to give you a sense that not all of them do. So this is the guy. Oh, sorry. Oh, yeah.
Like, normally I wouldn't think about like deleting the acronym and purposely, but
What?
that was okay.
Yeah, there's not a take-home message that in the future you should give.
Do not do that.
No. So this is something that because again, we had literally said to ourselves and to everybody else in the cath lab, in 10 minutes, we're going to call it if she doesn't come back after repeated shocks. We've given her everything. We've given her 10 minutes of perfusion plus medication onset.
Yeah.
And at the end of that 10 minutes, still not recoverable. So it was either turn off the ECMO and be done, or try this one thing that had worked in our lab on tape.
Oh, you have a verbal.
Cardiopulmonary.
There's intra-resuscitation cardiopulmonary. It's a hard reboot.
Yeah.
But it's not to be done in a code situation. This is never going, well, I don't know, I shouldn't say never, but it's not anytime soon will it show up in the guidelines. It will not be part of your ACLS card anytime. Okay, so case 4, got bystander CPR, many shock, amnio, difficult airway, and that's the theme. He got the impella because his RV or LV function was so horrible that he had 1%, and that was generous on his bedside echo once the ECMO was made. He had an LED that was completely out, which is the interesting for it. He needed a lot of suppressors, and he had a lot of He was getting shocked the whole way upstairs. Next thing on ECMO, you can sort of take your time with it. But still, getting shocked in the CT scanner, getting shocked up on the floor. This is his first echo. The impella is in here in the LV, and it's just stony, thick ventricle. Basically, diastolic contracture. The short axis, again, shows just basically complete collapse. This is his head CT. He already has severe anoxic injury and cerebral edema on the way up from the cath lab to the ICU. Basically not recoverable, but we gave it a shot. Got a brain perfusion scan 2 days later that showed no blood flow to the brain. He declared brain death, which we're not going to do. So this is a guy, we had 2 of those, and both of them have been from people who had a PO2. That's what part of what sparked, and I said this is a continuous effort of quality improvement. It sparked those criteria I talked about for the PO2 and the O2 stat and the end title. We wanted to be a little more selective, so we didn't have as many institutes. One of the 2 people was an organ donor and really gave organs, so there was a benefit there in some sense, but it's still a tragedy, and so it's not something we're trying to do. Still trying to, help the people we can help and not help the people we can help. So just to look at the outcomes, just to give you a sense of how things are going, so we get a false sense of goodness. We've had 8 people that have fallen into the protocol. Average age is 60, average downtime is 8 minutes. Half of them have gotten bystander CPR. 38% of them have intermittent loss. So a little over 60 minutes to get to the cath lab on average. And it's a rough, that's a relative contraindication, a 60-minute thing, depending on how everything else looks. End-tidal CO2 average is 32, so it's actually usually pretty good. ABG is pH 7.1, max is 14. They go to the cath lab, half of them have gotten ECMO, 38% of them have gotten balloon pumps alone, and 1 guy got ECMO. The outcomes from all that, 1/4 of them have died in the cath lab. We have not admitted them because they just want to recover them. The 25 or a fourth of them went to CCU, a quarter of them were brain dead on the floor, and a quarter of them are still in the hospital. So the complications, one guy bled, 2 people have had seizures, and 2 of them had severe hypoxia, which preceded the declaration of birth. So if we now you apply those same criteria to the population, we don't have anybody who's still because people are dying. Okay, so common problems, just to give you a sense of what we're up against. First 4 to 6 hours, they're largely unstable, and we need a lot of, basically running a code for 4 to 6 hours, even with ECMO. A lot of vasoplegia, we need some vasopressin. If you don't put them on ECMO, they have cardiac collapse about 2 hours later, almost invariably. They become unresponsive to epi, and they end up on ECMO. The bleeding issues certainly come in once they're cooled to target temperature. A lot of them are actually cold before they even get to the pool. So they start bleeding early. As soon as you warm them up, that gets better. But they have a lot of bleeding from everywhere. Sites of trauma from the incubation, mouth or nose, just from randomness, or around the cannula. We do adjust the target temp for that. So our target is usually 33 to 34. So if they start to bleed seriously, at least we go up to 34 to 35, usually 35. Control bleeding pressure. And then we adjust ACT goals as well. So if they have moderate bleeding, it's 160, maybe. If they have severe bleeding, 140 to 160. Or the usual is 180 to 200. Rewarming is another, once they get cooled, things start to settle down. Then when you rewarm them, it becomes unstable again. More vasoplegia, usually need a little pressor, at least for a short period of time. The pressor of choice is usually vasopressin, because there's sort of relative lack of effect on pulmonary vasculature. We use vasopressin and epi, inotrope. They do, 2 of them have had seizures. Once we warm them, all of them are going on EEGs at this point. If they do have seizures, we call neurocritical care and put them on Keppra. And then some of them have very prolonged neurologic recovery. We started some on amantadine. There's some data from Callaway of that actually being beneficial to people, at least some group of people. And we started now pretty short after 2 of the 3 people became more active, but haven't necessarily woken up and really there. So things for you to know, because again, so let me just take a step back and say how you will now be involved over the starting Monday road. The night person is now going to be primary coverage for these people at night. I will still be imminently available, so that night person can call me at a whim, even if you just want to chat. Yeah, I know. It's quite a perk to do that. So during the day, the CSI fellow will be covering these people again as the first call person and seeing them and rounding on them in the morning, at least for the first week with Dr. Yanako. After that, I'm not sure what the attending situation is going to be, but we're going to work on that. That said, you'll still have me during the day to call if you need help. I'm just going to be doing neurocritical care things. So I may be seeing some of your patients. And then I will still be checking in on them as well because I care. So you'll be hearing from me possibly little things here and there. When these things happen in the cath lab, either night or daytime fellow, these are the things you want to ask. I will provide this list to all of you. So you'll get this, you don't need to memorize it. But it's all the things about the arrest they don't tell us in the report. Then you also want to get some information from the cath lab if you weren't there for the whole case. Again, I'll give you that list. There's a whole slew of different orders, order sets, and we're trying to combine it all into one order set. So these are things that will be much easier for you hopefully by next week. They all get CT heads on the way up.
We still use the thermal guard cooling?
You don't have
Or is it part of that ECMO Cardiohelp?
because the ECMO can cool, we've been using that for the most part, though the thermal guard comes with additional access to the nurse's budget. So we will put it in on some people. They get EEGs, they get CTs, they get echoes, they get a lot of things. Again, because any one of these tests can give us a sense of who we should, or selection criteria for the future. Again, we've already been changing the protocol because of some of the results that we've had. And these are all the order sets, so you can see there's a whole bunch of them currently, but we're going to consolidate that. A whole bunch of labs, and after they rewarm, they get a whole other set of things, including the orders and consults, including palliative care for everyone. When you hear about an echo or an ECMO, you have to call through the surgery, and you have to call me. I'll know that, but you can call me if something's going on. And that's it. This is going to be an evolutionary process. We're going to be changing things as we go.